Good afternoon, everyone, and welcome to our Thursday afternoon webinar. I'm Melinda Bikini. I lead the patient advocacy team with the Cholangiocarcinoma Foundation, and I am thrilled to be joined today by Dr. Katie Kelly. She's a professor of clinical medicine at the University of California, San Francisco Department of Medicine. Dr. Kelly is a GI oncologist who specializes in hepatocellular, bile duct cancers, and gallbladder cancers. Her research interests include developing clinical trials of new treatments and combination therapies for these cancers, including immunotherapy approaches and translational research to identify molecular and genetic biomarkers of response. Thank you, Dr. Kelly, for joining us. And as always, we will open up after Dr. Kelly's presentation for a Q&A. So we invite you to put your questions into the chat box, and we will get to your questions at the end of the presentation. And as always, if you could keep them general in nature, as Dr. Kelly won't be able to answer any personal medical questions. And I will turn it over to you. Thank you.
Great. Thanks so much, Melinda. I'm extremely excited to talk about towards the end of this talk, a new clinical trial that is just recently launching nationwide and eventually internationally. And thank you for having me to the Cholangiocarcinoma Foundation. And I'm also speaking on behalf of colleagues from Servier about the IDH1 inhibitor Ivosidenib and its use in immunotherapy. So the title of this talk is New Directions in Treating IDH1-Mutant Cholangiocarcinomas. And here's the outline of what I'll cover. First, we'll start with some background on IDH1 mutation, including standard treatments for cholangiocarcinoma with and without IDH1 mutations, and how we handle IDH1 inhibition after standard chemotherapy. And then we'll move into this new approach that's being launched with the phase 1/2 trial of Ivosidenib combined with immunotherapy, the rationale and the design of this new trial, and then move into the question and answer session, as Melinda alluded to. So beginning with the background, I think all of us know that cholangiocarcinomas occur within the family of biliary tract cancers, and are uncommon, though the incidence is rising, unfortunately, worldwide. There's about 2 cases per 100,000 people in the US as of 2017 data. And cholangiocarcinomas and biliary tract cancers in general have very complex anatomy. And you can see that in this cartoon here, which is just a cutout of part of our GI tract, doesn't even show a lot of the complicated details like the stomach, and most of the intestines are even not shown in this picture. But we can see that we divide cholangiocarcinomas into the intrahepatic component, or ICC, which are cholangiocarcinomas occurring in the tiny bile ducts within the liver. Then there's perihilar bile duct cancers, or cholangiocarcinomas, that occur at this bifurcation of the bile ducts up until where the cystic duct takes off entering the gallbladder. So this little tiny area that's a very important door to the liver part of the bile duct. And then distal bile duct, distal cholangiocarcinoma refers to cholangiocarcinomas starting below the cystic duct take off to the gallbladder and down to the head of the pancreas. So this is very complex anatomy. And in addition to being complex anatomically, the biology, or the DNA and the immune microenvironment and the other molecular features of cholangiocarcinomas are also very heterogeneous and track somewhat with the anatomy, meaning the genetics of intrahepatic cholangiocarcinomas are distinct from those of perihilar and from those of distal cholangiocarcinomas. And so looking at some of the most high profile mutations that we know about to date, and again, we're always hoping that we'll learn, and we are continuously finding new potential therapeutic targets along the way. We see from these set of tables that different parts of the bile duct anatomy have different tendencies towards mutations and other molecular aberrations. And so here we can see in the gallbladder, for example, it's more likely to have a HER2 amplification or overexpression, whereas in the extrahepatic, or including perihilar and distal cholangiocarcinomas, we're more likely to have PRKACA and B mutations, or ARID1A and HER2 new mutations, distinct from amplifications. And then what we'll be talking most about today are intrahepatic cholangiocarcinomas. Again, those arising within the small ducts of the bile duct within the liver itself, where we see some really unique and interesting aberrations, including FGFR2 fusions or rearrangements, and IDH1 and 2 mutations. And today, again, we'll be focusing on IDH1 mutations and their targeted agents, And the prevalence of those is about 10 to 15% when lumped with IDH2, and they almost exclusively occur in the intrahepatic location, these small ducts within the liver. So here's a box just to show this is the focus of today's talk. And so what's the rationale for studying these mutations as a treatment in cholangiocarcinoma? Well, we know IDH1 mutations can occur in multiple types of human cancers, though they're overall rare. The most common are in gliomas within the brain, chondrosarcomas in a musculoskeletal system, leukemias have also been shown to have IDH1 and 2 mutations, and cholangiocarcinoma. So rare tumor types, but recurring, that this is a driver of certain types of cancers. This mutations in IDH1 are a driver of certain types of cancers. And what happens when one has a tumor with an IDH1 mutation is that the aberrant overactivity of this IDH1 gene causes the production of its product, which is called an oncometabolite, meaning it's a protein product of the gene that drives tumor growth or cell growth by blocking the differentiation or blocking the maturation of those cells that have this mutation. And this product actually causes a lot of changes around it in the cells itself and in the microenvironment, including that it promotes cell growth and without differentiation, but also inhibits the immune system around it. And so we're learning increasingly that the immune microenvironment around IDH1 mutant cholangiocarcinomas is not competent to recognize and fight this cancer. The immune system is not seeing it as well as it should. So Ivosidenib, or Tibsovo is the brand name, Ivosidenib, the scientific name, is an oral small molecule inhibitor of the mutant IDH1 enzyme. And in a phase 3 trial called Clarity, the IDH1 inhibitor Ivosidenib was shown to improve outcomes, which I'll come to in a minute. So that brings me to the next part of the talk is how do we treat cholangiocarcinomas, and particularly intrahepatic cholangiocarcinomas that harbor this mutation, IDH1 mutations? And so when we look at our standard therapy as our first approach to treating advanced cholangiocarcinomas, so tumors that can't be removed by surgery or have metastasized, our best foot forward currently is the combination of chemotherapy with immunotherapy with a drug such as durvalumab, or I'll show you in a minute data for a different immune checkpoint inhibitor called pembrolizumab. And what we see from these two curves here is that chemotherapy in orange has an improvement in overall survival compared to no chemotherapy or compared to just a single drug chemotherapy. In this case, the orange represents a 2-drug combination called gemcitabine plus cisplatin, which is our historic standard chemotherapy. But just in the past 2.5 years or so, we've learned that adding an immune checkpoint inhibitor to that chemotherapy improves the chances of people surviving longer with this treatment with cholangiocarcinomas, and also having better tumor shrinkage rates, and that this benefit persists over time. And we can see, in fact, that it's even accentuated over time. And when we see this kind of curve where the treatment benefit gets more pronounced, meaning the people who are still alive on this curve are greater in proportion the longer we follow them, that makes us think that it's actually the immune system working here, that we're really getting the immune system to learn how to recognize that cancer, to learn those T cells to see the tumor and fight it for the long term. And that's obviously what we want. We just want it to be a much higher proportion of people. So we want many, many more people to be on these curves that have these durable responses. But this is a good start in that we're seeing more and more people, a higher proportion of people having prolonged immune-based survival. And that correlates with shrinkage rates, where more people are showing tumor shrinkage when we add immunotherapy to standard chemo. The same results were shown with a different immunotherapy, pembrolizumab, added to the same chemo, where with a slightly different trial design where the chemo was continued for longer, we see that then there's a sustained benefit to adding immunotherapy. Now, these data, again, are in all patients, not just IDH1 mutation carriers. But they tell us that our standard best treatment is the combination of chemo plus immunotherapy. Now, when we look at different subgroups of, so this is our current standard treatment for everybody. We're trying to figure out, does it work equally well whether you have one FGFR2 fusion mutation or a BRCA mutation or an IDH1 mutation? And so what this type of graph is showing us here is whether the treatment performs similarly according to the particular mutations that we're looking at. On the left, there are listed some of the more common mutations that we have enough data to wager a guess on based on the numbers of patients. And we can see all these little dots are falling to the left of this line in the middle. And that tells us that the addition of the durvalumab immunotherapy with chemo tends to do better on helping people live longer. And that's what we want to see, obviously. And we can see most of the results are falling pretty consistently to the left of this line. These little tiny dots tell us that we have just very few patients, not enough numbers to be statistically significant most of the time. So the bigger dots are the ones we have more confidence in. And the big picture is that as far as we can tell, this combination seems to do improve survival in all of these mutation subgroups. And here's IDH1, and we can see that people getting the immunotherapy tend to have longer survival, just like people without the mutation for IDH1. Now, when we look a little deeper at other clinical endpoints, though, there's a slightly different picture here. This chart shows us the response rate. ORR stands for objective response rate. And it's kind of hard to see the coloring here, but the two bars on the right for each of these pairs are the mutation carriers, and the two on the left are the non-mutation carriers. And we can see in most of the groups of these are the mutations shown at the top. And we can see in most of the groups, the people who got the purple tended to have better shrinkage rates. That's with durvalumab than people who just got chemo, whether they had the mutation or not. So again, the colors are a little hard to see, but the fainter colors are the people with the mutation. That's supposed to be little bars there, or a hashed line. But when we look at the IDH1 group, we see something that's a little bit off kilter in that the people with IDH1 mutations seem to have a lower response rate to both the durvalumab containing chemo, durvalumab plus chemo and chemo alone, both the purple and the yellow bars here, compared to people without the mutation. And so that begs the question of is the response rate as good as we want it to be, or as good as non-mutant people? And again, the numbers are really small, so we can't draw definitive conclusions, but it's a sign that perhaps something is amiss. We looked at progression-free survival, another metric of how well the treatment works. And we see a little, again, a very small dot, so the numbers aren't big enough to be statistically significant. But again, just a signal that maybe the IDH1 mutation patients aren't doing quite as well as other groups with the combination of immunotherapy to chemo. So again, just an early signal without a lot of data, but here's my summary right now. That the overall survival with immunotherapy does favor including immunotherapy with chemotherapy, but we're seeing maybe less degree of benefit when we look at other efficacy endpoints like progression-free survival and response rates, which make us really want to look more carefully at what we're doing and how we could do better with IDH1 mutation in particular. So turning to what do we do next? Let's say that our first-line therapy stops working in someone with an IDH1 mutation. What are our subsequent options? Well, we have standard chemotherapies like FOLFOX and FOLFIRI chemotherapy, but there's also, as of quite recently, the option of a targeted therapy called Ivosidenib, as I mentioned earlier, again, brand name Tibsovo, which is an IDH1 inhibitor, which has shown improvement in progression-free survival in patients with IDH1 mutations compared to placebo. So there have been two major published studies of IDH1 inhibition with Ivosidenib in cholangiocarcinoma, a phase 1 trial and the phase 3 Clarity trial. So the Clarity trial design is shown here, where patients who had prior chemotherapy with gemcitabine or 5-FU based treatment, and most people had gemcitabine plus cisplatin, which is again our standard treatment. So patients who had at least one prior therapy, but no more than 2 prior therapies, and had a known tumor containing an mutant IDH1 gene, were randomized in a 2-to-1 fashion to either the Ivosidenib targeted therapy or to a matched placebo. So again, we, the doctors and the patients, did not know which group they were in during the trial. Now, if somebody had progression of their tumor, meaning the tumor grew on the CT scan or MRI scan that we got on treatment, this study was, we thought, very favorably designed and for patients and for us doctors who always want to give our patients the best shot we can, thanks to a lot of advocacy from the Cholangiocarcinoma Foundation that helped build this design into the trial. So it allowed patients who had progression to do what's called crossover. If their tumor started to grow and they were in the, if someone's tumor started to grow at all, we had permission as doctors to reach out to the clinical trial central office and say, was this person in the placebo arm or in the Ivosidenib arm? And if the person was in the placebo arm, we were able to allow them to switch over to the Ivosidenib arm and get the Ivosidenib, which again is a really important feature for all of us. And so here was the primary endpoint results, which was progression-free survival. We can see that patients in the red curve, the Ivosidenib arm, had a substantially longer time before the cancer started to grow again, compared to the placebo arm, the no treatment arm. And again, this was a blinded study, so these results were very pure scientifically in that neither the doctors nor the patients nor the radiologists had any clue which group people were in. So this was a significant benefit, a very low hazard ratio, indicating very strong statistical significance. But, when we look at the numbers, we can see, while this is a big improvement, the average patient is still not where we want them to be. So of course, we'd rather people be on the red line than the blue line, but we wish that far more patients had these prolonged responses than we see here. So a subset of patients had really dramatic prolonged responses, but on average, it's still not quite where we want to be, even though it's an improvement. Now looking at the other endpoint in question, the key secondary endpoint of overall survival, or OS here, we saw an improvement for Ivosidenib. It didn't quite reach statistical significance, but we have to remember that a lot of people on this placebo arm green line actually crossed over, because when they progressed, they went on to get Ivosidenib. And so they got the benefit of the drug, which then makes it hard to measure a survival improvement. And so the statisticians involved in this study performed a very fancy, complicated analysis called rank preserving structural failure time model, which then used calculations to assess how patients would have performed without that crossover. And we can see that this analysis did show statistical significance and a much bigger delta in a much bigger difference in how long people lived with the drug compared to how they would have performed without the placebo, without crossing over from placebo. So again, this reassures us that the progression-free survival benefit of Ivosidenib does likely translate into a meaningful survival benefit in people getting Ivosidenib after 1 or 2 lines of systemic therapy. So again, a big improvement, but we want to do better. And so right here, this slide shows us the worldwide approvals for Ivosidenib globally, starting with the US in 2021 and now in these other parts of the world. And brings us to, again, what's the next step from this? We, again, have a very significant incremental improvement, and what can we do next, having learned quite a bit from the Clarity phase 3 trial I just showed you. So I mentioned earlier that IDH1 mutations seem to cause some defects in the immune response to the cancer. And here's some data showing this in patient samples with cholangiocarcinoma, predominantly from the earlier phase 1 trial. And so for those patients on the line, this is the kind of, I'll make an aside comment here that the data I'm about to show you that Servier and Agios, before them, the drug companies, and a lot of the basic science researchers have put together is really based on all the tumor biopsies and the samples that patients like you have contributed to these research studies. And they're critically important to informing the next hypothesis, and as you'll see, the next generation of clinical trials. So this is a huge thanks to all the patients who contributed biopsy samples along the way and blood samples. And so what this slide shows is that there's a difference in the immune cells around IDH1 mutant cholangiocarcinoma tumors compared to cholangiocarcinomas that don't have the mutation. Here you can see the little WT stands for wild type, and that's a fancy genomics research way of saying normal without the mutation is wild type, and M stands for mutation. We can see there's a lot more T cells, dark, which are stained in this slide with a bluer color stain or more purple stain. So there's a lot more T cells, and actually brown here is the CD8 positive stain, but there's a lot more lymphocytes and CD8 positive T cells in particular in the wild type, which tells us the immune system is there and hopefully working to some degree. And conversely, in the IDH1 mutation setting, there are a lot fewer T cells. And of course, to respond to immunotherapy and to fight a tumor, we need T cells. And so it's a problem if they're deficient. So that's one important clue of what part of the problem is in IDH1 mutation samples. And when we look at samples from the Clarity, the phase 3 trial, also from patients who enrolled on the trial, we can see a similar finding that patients with IDH1 mutations had on average a statistically lower number of lymphocytes in their tumor. And this is shown in just this example where there's more dark staining lymphocytes in the wild type WT normal setting here compared to the mutant example shown on the right. And in the plasma, in patients with this elevated plasma 2-HG, which if you remember back, that's the oncometabolite, the fancy word for the byproduct of the IDH1 mutant gene and protein once it's transcribed. Patients who have IDH1 mutations and have its downstream byproduct end up having a higher proportion of sort of immune suppressive cells and a lower proportion of the immune effector cells. And so basically a more suppressive immune microenvironment when you have the IDH1 mutation. So fewer of the effector and activated tumor fighting cells and more of the suppressive cells in their tumor microenvironments. And then this is an interesting recent paper that showed a very similar finding that the 2-hydroxyglutarate from IDH1 mutations in glioma, again, the type of brain tumor that also tends to have a high proportion of IDH1 mutation patients, that this same byproduct also has been shown to impair the actual function of T cells. So now there's a lot of data that this oncometabolite from IDH1, the 2-hydroxyglutarate, impairs T cell function, also impairs T cell numbers, and makes a higher proportion of the immune suppressive cells like macrophages. So all in all, reducing the immune system's ability to fight the cancer. And so here's, what can we do about this is the next question, of course. And so here's an interesting mouse model from Harvard, now Nabil Bardisi and team's lab, that showed that if you inhibit IDH1 and its downstream metabolites by Ivosidenib, the same pill we use in the Clarity trial, you get more T cell recruitment. So you can actually bring back more of those T cells that you want. And when you give Ivosidenib here, this is AG120 is the scientific name for Ivosidenib before it was named. And importantly, if you combine that with immune checkpoint inhibitor with a CTLA-4 antibody, we can see some really substantial growth inhibition in a mouse model of IDH1 mutation with this blue line here below showing Ivosidenib plus the immune checkpoint inhibitor anti-CTLA-4. Well, where quite dramatically this mouse carrying an IDH1 mutant tumor shows pretty significant tumor decrease in volume compared to either the Ivosidenib alone or the anti-CTLA-4 alone, or just control where all of them kept growing. So this is a quite dramatic finding. So Ivosidenib helped there be more T cells in the mouse model, and Ivosidenib plus the CTLA-4 inhibitor inhibited the tumor growth substantially in this model. So this is quite exciting. So this slide is sort of a complicated slide looking at a variety of different immune checkpoint inhibitors, a variety of immune checkpoint molecules in tumor cells themselves. And we can see that giving Ivosidenib, so these are patient samples again, so huge value to collecting these samples, and thanks again to all the patients who contributed. We see on average that these immune checkpoint expression markers started low, and then by cycle 3 day 1 or C3D1 of receiving the Ivosidenib for about 2 months, the checkpoint expression increased on average, suggesting potential for benefit from an immune checkpoint inhibitor compared to Ivosidenib alone, because we're seeing an increase in these target expressions. And now just to show a couple anecdotal published data from patients who've gotten the combination of an immune checkpoint inhibitor during or after Ivosidenib. Here's a very recent published case report of a patient who was treated with Ivosidenib for IDH1-mutant cholangiocarcinoma, and then went on to receive a CTLA-4 inhibitor plus an anti-PD-1 immune checkpoint inhibitor, and had a very dramatic tumor response in a lymph node. You can see here's one spot there, and actually I think right here is part of it too. and had, here's another lymph node with this asterisk, and it showed significant tumor reduction for prolonged beyond 6 months. So again, indicating creating a provocative hypothesis that perhaps Ivosidenib was helping the immune system respond to treatment after the fact. So with that, I'm going to go to our summary of this rationale and then present this new clinical trial based on these data. So the data and human samples I showed you from the phase 1 and phase 3 trials of Ivosidenib show that inhibiting IDH1 improves, well, previously the clinical data shows it prolongs progression-free survival in actual humans, but the treatment itself on the molecular level and on the cellular level improves lymphocyte counts, as well as upregulation of immune checkpoint expression, suggesting again a potential improvement in response to immune checkpoint inhibitors after or combined with Ivosidenib. And the metabolite of IDH1 2-hydroxyglutarate is itself directly an impediment to T cell function, and also lowers T cell numbers. So if we can inhibit that metabolite, we could improve our T cell numbers as well as their functionality in the tumor microenvironment. And then from the animal models, the combining immune checkpoint inhibition via CTLA-4 inhibition in particular with Ivosidenib showed a substantial improvement in tumor shrinkage in mouse models. So all of that data has led to the genesis of a new recently launched phase 1/2 clinical trial with a safety lead-in phase followed by a larger dose expansion phase. And this is the full title, open label multi-center trial, investigating the safety, tolerability, and preliminary activity of the IDH1 inhibitor Ivosidenib in combination with nivolumab, which is an immune checkpoint inhibitor, and ipilimumab, which is a CTLA-4 immune checkpoint inhibitor, in people who have had previously treated unresectable or metastatic cholangiocarcinoma with an IDH1 mutation. And this is the searchable clinicaltrials.gov number. So this slide shows an overview of the design of the trial. So the patient population is people who have had 1 or 2 prior lines of therapy, which we call in oncology speak second or third line treatment context. So it'll be people who are on their second or third try at treating their cancer. And everybody needs to have an IDH1 mutated cholangiocarcinoma because this is focusing on the biology of IDH1 mutation. The first part of the trial will be a very small and carefully scrutinized cohort of up to 12 patients that will receive the standard dose of Ivosidenib, which is 500 milligrams per day, combined with these 2 immune checkpoint inhibitors one of them is called nivolumab, which is an anti-PD-1 inhibitor, and the second one is called ipilimumab, which is an anti-CTLA-4 inhibitor. And again, this is the type of drug that was so active in combination with Ivosidenib in the mouse model. And all patients will be observed for up to 42 days to evaluate if there are any unacceptable toxicities from this combination. If there are any treatment-related toxicity, the dose of Ivosidenib can be decreased and an additional 6 patients can be treated. After that lead-in safety phase, the trial will proceed to a larger expansion phase with 2 groups of patients. The first group will be people who have cohort 1 will be people who have not had a prior immunotherapy agent, such as durvalumab or pembrolizumab, in this cohort, patients will get Ivosidenib plus the 2 immune checkpoint inhibitors. In the second cohort, the treatment will be the same in both of these. So everyone will still get the Ivosidenib and the 2 immune checkpoint inhibitors, nivolumab and ipilimumab. But the second group will be people who have already had an immune checkpoint inhibitor as part of their first line trial, as part of their first line treatment. So the primary endpoints of the study are safety and tolerability, and to make sure that the doses are combined safely. We expect that there won't be too much overlapping toxicity. One, because Ivosidenib itself is quite well tolerated with very minimal toxicity, and two, because the mechanisms of action and mechanisms of toxicity from the immune checkpoint inhibitors, we don't think is going to be compounded by the Ivosidenib in any way, based again on their mechanisms of action. And third, I showed you that case report, but we all have experience in the clinic of giving these drugs very close in succession of immunotherapy, then Ivosidenib, or Ivosidenib, then immunotherapy. And anecdotally, we have not to date seen combinatorial toxicity, at least when given sequentially in close proximity to each other. Secondary endpoints are to measure drug levels, which we call pharmacokinetics, measuring the activity of the drug on and the levels of the drug at certain time points after dosing, as well as the pharmacodynamics, meaning the activity on its target enzymes. And there are a host of exploratory endpoints, including looking at the actual immune microenvironment to understand exactly what's happening on the lymphocyte level, or as well as other immune suppressive cell level when given in combination. So the trial does include paired biopsies at the beginning, at cycle 3, day 1, and at the completion of study to really understand why things are happening in the tumor microenvironment when these drugs are given together. And in the expansion phase, the primary endpoint is response rate. How much do the tumors shrink? And the secondary endpoints are quite similar to the ones I just mentioned. Safety and tolerability will be measured for all patients. And then there will also be pharmacokinetics and pharmacodynamics and biomarkers to assess exactly what's going on with the drug levels themselves. So key inclusion criteria are patients need to be greater than 18 years old, have a documented IDH1 mutation on local testing, have to be fit and healthy enough to be part of a clinical trial. We call that, we measure that using a metric called performance status, which assesses how active people are and how strong they are to be out of bed and active on a daily basis. Have a diagnosis of unresectable or metastatic cholangiocarcinoma that is measurable on a CAT scan, so we can tell how much this tumor shrinks reliably by measuring it from time point to time point, and have had at least one prior systemic treatment, such as gemcitabine cisplatin with or without an immune checkpoint inhibitor, and no more than 2 prior systemic treatments, just so the results can be comparable to other historic data, and also make sure that it's safe to be giving these treatments. Key exclusions, reasons that people would not be eligible to be part of this trial, include prior treatment with Ivosidenib or any other IDH1 inhibitor. That's not permitted for this trial. People who have active autoimmune disease needing steroids or other immunosuppression also are not eligible, because it's not safe to give this immune checkpoint inhibitor combination in somebody who has a serious autoimmune disease such as Crohn's disease or colitis. People who haven't recovered from their prior therapies, such as severe low blood counts or neuropathy, or severe neuropathy, mild neuropathy is allowed, but any ongoing severe toxicity from prior therapy is an issue, but hopefully we can help people recover from that and then reevaluate. The treatment is actually pretty straightforward. Everybody on the trial will get the Ivosidenib dose, probably 500 milligrams daily, assuming that's the dose that moves forward from the safety lead-in phase. And those are 2 pills taken together once a day. And then everybody will get the first immune checkpoint inhibitor called nivolumab, which is given intravenously over about 30 minutes every 3 weeks for 4 doses. And then it switches to once a month every 4 weeks for up to a total of 2 years. And then everybody also will get the CTLA-4 inhibitor, another immune checkpoint inhibitor, which targets the CTLA-4 immune checkpoint called ipilimumab. And that's given every 3 weeks for a total of 4 doses over a maximum of 12 weeks. So 4 doses total. And that's based on the standard use of ipilimumab. It's only given for 4 doses, and it's because of its immune-related toxicity over time. So here are the sites in the United States that will be open for this trial. And we're very proud that we just got it activated at UCSF in the past week. And with that, I'll summarize the high points here, which is that IDH1-mutant cholangiocarcinoma is a very important subset of predominantly intrahepatic cholangiocarcinoma. It accounts for about 10 to 15% of patients with intrahepatic cholangiocarcinoma. The IDH1 inhibitor, or excuse me, the mutant IDH1 inhibitor, Ivosidenib, is FDA approved and approved in the United States and in multiple other countries based on its phase 3 clinical trial data from the Clarity trial, which showed that it significantly improves progression-free survival, meaning the duration that the tumor is under control and either shrinking or not growing after 1 or 2 lines of prior treatment in people with mutant IDH1 cholangiocarcinoma. And what I've just shown you is the preclinical and clinical rationale for this recently launched phase 1/2 clinical trial of Ivosidenib combined with 2 immune checkpoint inhibitors, nivolumab, which is anti-PD-1, and ipilimumab, which is anti-CTLA-4, and based really on people's contributions of their data and samples from the Clarity trial and the preceding phase 1 trial. So here are some of the high-level metrics about the trial and the clinicaltrials.gov NCT link. With that, I'll conclude and say thank you so much for your attention and open up to any questions.
Thank you so much for the presentation, and I will get to the questions. One I'm going to ask right away, and I'm sure it'll probably come up, but for those previously treated patients with IDH1 inhibitors, for those patients who might be on one right now, is there any rationale to asking their doctor to add that it be Nivo if they don't qualify for the trial?
That's a great question. So right now, I don't know enough to say. I'm certainly looking forward to getting early results from this trial as quickly as possible. So because you're right that all 3 of these drugs are FDA approved, I think we can't espouse that approach until we have more data. But I certainly hope that this is something that will be easy to translate to clinic for people just like that, because I have patients like that as well.
Okay. First question, has research shown differences between those who do and do not benefit from long-term use of Tibsovo?
No, not to my knowledge. To date, there's certainly been analyses of other co-mutations, meaning like not just the people's tumors will have an IDH1 mutation before getting Tibsovo. Of course, there also are other mutations that can co-vary with IDH1. But so far, I don't think we've found any compelling or conclusive information on why some people do and don't respond to Tibsovo. It's a great question, and hopefully we'll learn more from some of the immune correlates, because it could be something complicated or more complex than just the tumor mutations, but also related to the immune microenvironment around the tumor.
Okay, thank you. Would you include any patients who had successful resection, then had oral chemotherapy such as capecitabine, but now have a recurrence, or would they have had to do the Gemcis or Gemcis Durva to qualify?
I need to look carefully at the eligibility before I answer, but I think that's a great question. It may be that if somebody recurred within 6 months, so if it was an early recurrence after capecitabine, that might be allowed. But if it's okay, Melinda, I can maybe follow up with you after this.
Absolutely. We'll be happy to get the answer back to the community. Why is Ivosidenib currently a second-line treatment versus a first-line option for IDH1 patients?
So that's a great question. Right now, so it was studied in the second line and third line setting, meaning after 1 or 2 prior treatments. While it was a significant improvement compared to placebo, it has not been compared to chemo. And while our chemo regimen with gemcitabine and cisplatin plus durvalumab did not have as favorable a PFS and response rate secondary endpoints as the other mutation subgroups or wild type for IDH1, the overall survival still showed improvement. And the numbers are far too small to draw any definitive conclusions. So right now, this first-line chemotherapy that we have has the best data in terms of helping people live longer, which is our top priority at the end of the day. So right now, the data we have still definitively favors using chemo plus immunotherapy as what helps people live the longest in the first line. Obviously, over time, if we see dramatic benefit from a different strategy that will need to be reevaluated.
Okay. Does having any radiation therapy exclude you from the trial eligibility?
No, there just has to be, I believe, a 4-week washout from prior radiation. So there needs to be a little window of time to make sure people have recovered.
Will patients who develop IDH2 mutation qualify for the trial?
No, the Ivosidenib is purely an IDH1 inhibitor, so this approach wouldn't work for IDH2.
So can you briefly go over what was seen in the mouse models again?
Yes, so the mouse models are genetically engineered mice models of a cholangiocarcinoma cell line with IDH1 mutation. And the mouse data showed that giving Ivosidenib to the mice helped improve the number of lymphocytes in and around the tumors in the mice. So that suggests that blocking IDH1 and blocking its downstream metabolite 2-hydroxyglutarate, the 2-HG molecule from IDH1 mutation, helps the immune system be more normal around the tumor, and potentially more adept at responding to an immune checkpoint inhibitor. And the mouse model tested that further by then taking the same types of tumor mice and treating them with Ivosidenib plus an immune checkpoint inhibitor that was specifically a CTLA-4 inhibitor. And that showed that the combination of Ivosidenib plus the CTLA-4 inhibitor, much more so than either one alone or control, caused that downward line where the tumors actually shrunk dramatically instead of just slowing them down. They not only stopped growing, presumably the immune system was helping kill the tumors better than either Ivosidenib or CTLA-4 inhibitor alone.
Thank you for that. Do you mind going back to the slide with the locations again? You wanted to see the locations again?
Oh, of the trial?
Yes, thank you. So if a patient is already on Tibsovo, would it be recommended that they talk with the team to see if they should start this trial, or would they not qualify if they've already started?
Would not qualify if you've already had any Tibsovo.
Are lymphocytes and T cells the same thing?
T cells are a type of lymphocyte. There are also B cells, which are the other most common type of lymphocyte. And then there are some rarer sort of gray area subsets like natural killer cells and such, which are not quite the same as B and T cells. But so B cells and T cells are the two main categories of lymphocytes, and they're both important for the immune system to fight cancer. They're much more complicated than just calling them a B cell or a T cell. Within T cells, there are suppressive T cells that also can be called regulatory T cells that are counterproductive when we're talking about fighting a cancer. The immune system is a fascinating system in that it is full of checks and balances, better than our government probably, but it has lots of ways to try to keep itself even keeled, because as we can imagine, those of us who've ever known anybody or taken care of somebody or had an autoimmune disease, when the immune system gets out of balance, it can cause major havoc and major disease. If T cells are out of control, they can chew up our GI tract and cause horrible colitis and diarrhea and illness. Conversely, when T cells aren't working, they cause immune deficiency and infection or propensity to get cancer. And so they have to be balanced carefully. So within T cells, there are the sort of checks and balances T cells that kind of calm things down. And then there's the effector fighter T cells that are out looking for a fight wherever they're riled up. And so we want those effector T cells to be really tumor specific. We only want them to be fighting the tumor. And we want the normal checks and balances in place, like in our GI tract, in our skin, and everywhere else, so that the immune system doesn't get out of control. And so one of the big picture of this IDH1 immune microenvironment is that there's too much of the regulatory side, not enough of the fighter side on the immune system's part. And so the goal is to try to help your immune system be more active and to reduce the suppressive part caused by that 2-hydroxyglutarate component. And that's where the ivosidenib comes in, combined with the immune checkpoint inhibitor.
Okay.
And hopefully that will help it stay focused, because really the only place the ivosidenib would be working is where there's mutant IDH1, which is around a tumor. We don't have mutant IDH1 in our gut or in our heart or anywhere else. So that theoretically is, a tumor microenvironment marker.
Awesome. Should IDH1 mutated patients avoid first-line Durva with an aim of qualifying for the first arm of the phase 2 trial?
Well, that's a strategic question. One would be right in surmising that in the Western world, in places where durvalumab or potentially in future pembrolizumab are approved, that cohort 2 will potentially fill up quickly. But I can't advise that. I don't know. We don't right now. That our best foot forward is the combination with immune checkpoint inhibitors based on the TOPAZ-1 trial. We don't have mutation-specific data yet from the Keynote 966 pembrolizumab trial. We are ardently, advocating to get that data, but it will have to be after its regulatory reviews. So I don't know if I'm very curious to see if the Keynote 966 pembrolizumab data shows that trend towards slightly less favorable PFS and objective response rate for the IDH1 subgroup that we saw from the durvalumab combination. So I can't speculate what's the right answer there, but it is possible that the cohort 2 will fill up fast with the Western sites, the US patients.
Okay. So for a patient on standard chemotherapy with immunotherapy, how many cycles until they would qualify? Do they have to progress? What is the qualification for that?
There has to be progression on or after at least one line of therapy.
Okay. Are the checkpoint inhibitors expected to be effective against patients who have progressed on ivosidenib?
So to use the nivolumab ipilimumab combination after ivosidenib, I think the case report I showed was a patient who had dramatic response very soon after ivosidenib. So that's a hypothesis. I think it's a reasonable hypothesis to consider, given that there is some data for nivolumab and ipilimumab independently. It's not FDA approved in this context.
Okay. Are liquid biopsies successful in detecting the IDH1 or other mutations? How likely is it that a patient will show new mutations over time after treatment?
So liquid biopsies are very good at identifying IDH1, extremely good at identifying IDH1 mutations. It's not as common to have resistance mutations on IDH1 inhibitor therapy as, say, with FGFR2 for those who've been following the FGFR2 inhibitor resistance story. Resistance mutations are extremely common in the kinase domain. For IDH1, there is some data of a phenomenon of isotype switching, of getting a new IDH1 or IDH2 mutate, or excuse me, a new IDH2 mutation after an IDH1 mutation, but that's pretty rare, and we don't see that commonly, but it has been reported. Liquid biopsies are good at detecting both IDH1 and 2.
Okay. Can you speak to long-term side effects of Tibsovo for those of us who are on it for several plus years?
That's a great question. We've been very fortunate to have handful of patients on Tibsovo for a very long time in my location at UCSF. And it has not shown a propensity to have long-term side effects, and it has been a very well-tolerated drug from early to late use. People sometimes will have a little bit of, in our experience, occasionally a low-grade fever especially early in using it. I haven't seen that in people who have stayed on it for a long time. Sometimes a little loose stools, and it's hard to tell, if people have fatigue, it's hard to know if it's from the drug or from having a cancer to begin with. But overall, it's been a very well-tolerated drug from start to even in people who've been on it for a long time.
Okay, so is there any specific diet a patient should do if they have the IDH1 mutation or are taking immunotherapy? They're comparing it to the FGFR2 inhibitors and having to watch their phosphate levels.
Right. So not that I don't know of anything specific to IDH1 that I could advise for or against with diet. I think the one possible piece of advice is that with immunotherapy, we don't know whether it's a good idea or a bad idea to take probiotics or supplements that contain high doses of bacteria in them, like lactobacillus, for example. And there's some data that it may be counterproductive or negative to people on immunotherapy. So I usually tell my patients that I prefer, based on the data we have so far, that they don't take commercial probiotics, but rather just eat a healthy diet and eat, if you want to work on your microbiome, eat dietary sources like yogurt, kombucha, things like that, but not to take high doses of a probiotic, because we're kind of flying blind, and giving really large doses of one particular bacteria, a cluster of a couple bacteria, could be net negative in terms of our immune system that evolves from the gut in large part.
Okay. So in regards to the autoimmune criteria of the trial, if it's a controlled autoimmune disease that they're not taking steroids for, would they qualify?
I believe, yes, if it's not something that has any systemic therapy requirements and is not active.
Okay. And what are the expected side effects of the IPI and Nivo combination?
So the dose used in this trial is a slightly higher dose of Nivo and a slightly lower dose of IPI. There's several different ways to give Nivo and IPI together. Ipilimumab, when added to nivolumab, does substantially increase the chances of an immune-related adverse event, ranging from rashes to diarrhea to low thyroid to high thyroid to other endocrine abnormalities. Basically, when I talk to my patients, we try to cover that anywhere that our immune system travels from head to toe theoretically could get an immune-related toxicity. Most of them are extremely rare. But when you add a CTLA-4 inhibitor like ipilimumab to a PD-1 inhibitor like nivolumab, the chance of getting an immune-related toxicity significantly goes up. And so at the doses of, with the higher dose of nivolumab and the lower dose of ipilimumab used in this trial, the chance of an immune-related toxicity, at least extrapolating from other tumor types, is probably around 20% of needing steroid, a chance of having a reaction so severe as to need a systemic therapy, like steroids, to calm it down. We don't know exactly what that number will be in cholangiocarcinoma, but extrapolating from kidney cancer and melanoma and liver cancer, it's probably in that ballpark. And so we do need to watch really closely, especially during that 3 months when they're getting the two drugs together, and for probably another couple months after that, that will be the window of time that's the highest risk. And we'll be watching for things like diarrhea, for coughing, shortness of breath, and any funny out of the blue symptom that goes, from 0 to 60 really quickly. We say, oh, that could be the immune system causing problems in a place we don't want it to cause problems.
Okay.
I should add, though, I have one thing to add, though, is while we never want that to happen, there is data across a lot of tumor types that when people do get an immune-related toxicity, that is a sign that the immune system is also more amplified and active, and there are positive trends of correlation with tumor response. So, sometimes it's a positive in the big picture if someone gets this kind of side effect, where we might have to even occasionally hospitalize, but sometimes put on steroids, like I mentioned, or other immune suppression. But needing that does tend to correlate with the tumor having a good kick by the immune system too.
Makes sense. Okay. Can radiation be given in conjunction with Tibsovo? I think we asked that one maybe already.
For the trial or just in general?
In general.
Yeah, usually we'll take a break and a washout, just because we don't want to cause any increased toxicity in combination. I don't think I'm not aware of any data in combination, deliberately setting the two together.
Okay. How about hyperthyroidism? Is it a disqualifier for the trial?
I don't think so. It's not on in the immune suppression, but I can, Melinda, I'll follow up with you on that too to confirm.
Okay. And I think we answered.
I should clarify, as long as the hyperthyroidism is well controlled.
Well controlled. Okay. I will look over all the questions that are left, but I think we've got to almost all of them. I will end the last one with, if patients are interested in applying for this clinical trial, how would they do so?
So I think that I would go to the clinicaltrial.gov link that we provided and look for, and you can see on this map, the site closest to your home or closest to a place where you have a home-based kind of location, like where your family member might live, if not near your own home. And then ask your primary oncologist for a referral to that location if you don't happen to live in one of those cities already.
Okay, and you can also reach out to the Cholangiocarcinoma Foundation at advocacy@curecca.org, and we'll help you find a location near you. And thank you, Dr. Kelly, so much for this great presentation. We're excited to have a new treatment option for our patients, and we will go through the questions, and if there's anything that we didn't get to, I will send to you, Dr. Kelly, if you wouldn't mind answering, and then I can send it back out to the community.
Of course.
All right, thank you. The recording will be available on our website and our YouTube channel probably within the next 24 hours. And thank you again for the presentation. We appreciate it. Everyone have a wonderful day.
Thank you.
Thank you.